My name is Dr. Steve Edelson, and I'm the Chief Science Officer of the Autism Research Institute in San Diego, California. It's an honor to welcome you to this think tank at the United Nations on Aging and Autism. We're here to shine a spotlight on a reality that is only now coming into clear view. Autistic individuals are growing older, and with that comes new challenges and new opportunities that society has only begun to understand. First, I'd like to thank the Mission of Malta for their co-sponsorship and for working closely with me to make this meeting possible. I'm especially grateful to Alistair, who will be presenting later, and to Rachel and Victoria for their dedication and hard work in bringing this event together. I'd also like to extend my appreciation to the Autism Research Institute and to the Nancy Lorraine Marks Family Foundation for their support and encouragement. Finally, I want to thank the United Nations for providing us with this platform to gather as experts from around the world and to share our perspectives on a pressing issue in the autism community. We are also honoring Jacqueline Adenbaum, a parent and advocate who has contributed significantly to the autism community. She has organized support groups for parents at the United Nations and was the originator of the annual Autism Awareness Day at the UN, which continued to be an important international event on autism. Jacqueline, we thank you for your dedication to providing outstanding support and guidance to autistic individuals worldwide. Now to the task at hand. For decades, the field of autism has largely focused on childhood, on diagnosis, education, and early intervention. These are essential areas of work, but they have left us with a gap in our knowledge and in our systems of care. Autism is lifelong. Children grow up, and today, the first generations diagnosed in early life are entering their senior years. At the same time, many older adults are only now being diagnosed or coming to self-recognition after years of living without that understanding. This shift compels us to ask new questions. How does autism intersect with aging? What unique challenges do autistic seniors face in health, independence, housing, and social connection? How do we address issues such as dementia, hospital admissions, or long-term care for those whose needs may not fit easily into existing systems? Most importantly, how do we ensure dignity, quality of life, and opportunities for meaning and purpose in later years? These are complex issues, and no single discipline, no single voice can answer them. What makes this gathering so special is the diversity of perspectives in this room. We have clinicians, researchers, autistic self-advocates, family members, service providers, and international partners. Each of you brings insight from a different angle, and together we can create a fuller, more nuanced picture of what aging with autism means. I encourage you to speak openly, to listen carefully, and to build on one another's ideas. This is the spirit of a true think tank, collective exploration that sparks new connections and moves the field forward. So let us use this time well. Let us engage with candor, curiosity, and respect. Let us leave not only with a clear understanding of the challenges, but with the beginnings of a roadmap for solutions. And let us carry forward a commitment to ensure that autistic seniors are supported, valued, and heard. So thank you all for being here and for lending your time, experience, and voices. I look forward to a stimulating and impactful discussion. Thank you. I would now like to introduce Francesca Gott, Permanent Representative of Malta to the UN, who will share additional opening remarks.
Thank you very much, Stephen, and we are delighted to welcome you to today's think tank focused on aging and autism on behalf of the Permanent Mission of Malta, organized together with the Autism Research Institute and the Nancy Laurie Marks Foundation. Autism has increasingly become a subject of global attention. However, Malta's initiatives to support people with autism began in 2018, when Malta enacted autism-specific legislation, being one of the first countries worldwide to do so. However, we did not stop there. In 2021, Malta adopted a national autism strategy which consolidated achievements in areas such as awareness, family support, and self-advocacy. We also set ambitious goals, many of which call for research, collaboration, and innovation. Malta's priority to social development remains visionary, with the aim to continuously improve the livelihood of all citizens. Notably, according to 6.7 of Malta's National Autism Strategy, mandates the Autism Advisory Council to, and I quote, start a discussion working with all relevant stakeholders in Malta and abroad on the topic of autism and aging, to eventually also explore specific needs and challenges in this area and start working towards addressing them, close quote. In this context, it is especially timely that today's discussion takes place. Malta's view has always insisted that autism must not be viewed exclusively through the lens of childhood. Our national strategy was among the first to advocate for a life course approach, an approach that has since been emulated by others. Yet, the intersection of autism and aging remains an area where research and outreach are urgently required to better respond to the needs of an underdiagnosed and underserved population group. For countries such as Malta, with an aging population, the work you are advancing will have significant practical implications. Therefore, it is of significant importance to address community living and health for persons with developmental disabilities. Academia continues to play a key role in addressing systematic barriers, and therefore I would like to thank you for your participation today and your ongoing contribution to the field. We must continue to work towards a more equal and inclusive society, and we must ensure that no one is left behind. I wish you all a fruitful and engaging discussion. I thank you.
Thank you, Francesca. Okay, now I'd like to introduce Elizabeth Zwick. She represents the Nancy Laurie Marks Family Foundation, who helped co-sponsor this event.
Thank you, Steve. Is this on? The NLM Family Foundation, what we call the Nancy Laurie Marks Family Foundation, is so pleased to be co-sponsoring this important international gathering. As our proceedings begin today, I invite you to reflect on the implicit question here: why should we all care so much about autism and aging? We know that today there are far more autistic older adults among us than have been identified, and those numbers are certain to increase. After all, young people with autism grow up to be older people with autism. There is so little known about this population that we must focus now on identifying their greatest needs and developing the most effective approaches to meeting those needs. These are our shared concerns, but we may also each have our own why. In addition to our long-standing professional commitments in the field, many of us have family members, friends, neighbors, co-workers, or are ourselves aging with autism. What we do know is that, at least in the case of the United States, older adults are more often socially isolated than younger adults, and autistics are more isolated than neurotypicals. As the former U.S. Surgeon General Vivek Murthy has pointed out, social isolation and the resulting loneliness are both quality of life issues and quantity of life issues. Socially isolated people live shorter and less satisfying lives. When the needs of older autistic adults are left unattended, they suffer. And of course, their families and loved ones suffer. But in addition, whole societies are impacted when faced with, quote, overnight care crises that were in fact foreseeable. Societies are then forced to scramble at the last minute to meet the needs of a whole population that has been invisible or disregarded. That is inhumane, expensive, inefficient, and unnecessary. We can and must learn and prepare now. This means identifying and anticipating the needs of older autistic adults, including their experiences of the common changes of aging, as well as the unique challenges they face. We know so little about either. As we see on today's agenda, we need to know more about the biology of aging with autism, approaches to physical and mental health care, administrative barriers to health care, the benefits of diagnosis later in life, and the many financial, legal, and systemic issues that arise at that intersection of autism and aging. The NLM Family Foundation is grateful to all the participating researchers here and the professionals and concerned attendees here and from all over the world for your caring attention to these vital issues. There is much work ahead, so let us begin.
Thank you, Elizabeth. So we're going to now start the think tank. We actually have two moderators. The first half will be Thackeray to my left, and she'll have a few words. And then the second half will be Vanessa to my right. So they'll pretty much run the meeting, and I just hope everyone will be able, as I said earlier, share their thoughts and opinions on a lot of different issues that's going to be discussed today. And actually, we're not too bad regarding time. Okay, Thackeray.
Hi, everyone. My name is Dr. Thackeray Shafai. I am the Chief Science Officer of AID Canada and the Director of Professional Training for the Pacific Autism Family Network in British Columbia. I would like to introduce Chan Lee, University of Malta, and Dena Gassner of Drexel University. They will be discussing navigating healthcare systems and reducing administrative burdens and bureaucratic barriers. Thank you.
Hello, good morning, everyone. My name is Chan Lee from University of Malta. Today, I'm so excited and honored to be here to share the topic of navigating healthcare systems and reducing administrative burdens and bureaucratic barriers. And as you may know, more and more autistic adults are reaching the older age. And many of them, Yes, many of them were never diagnosed or misdiagnosed in their early life. And, but meanwhile, aging brings a lot of the complicated needs for them, like physical, mental, social. And this creates very unique situations. And, but unfortunately, most of healthcare systems are not yet ready for neurodiversity in their later life. And when we talk about accessing the healthcare systems, it is not just about finding doctors or treatments. It is also about facing a lot of the bureaucratic barriers. These barriers like endless paperwork, repeated assessments, phone calls, and fragmented services. And also these barriers turn essential cares into the exhausting suffering for them. So what's the consequences for that? And obviously you can see delaying their treatments, even sometimes they give up their treatments and overwhelming their families, undermining their dignities, and they're reducing the quality of life. Okay, oh, sorry.
And I'm the old autistic, right? And so I wanted to talk about a framework that we use to address these administrative burdens that people are facing. Administrative burden is noted for imposing hardships that are related to learning. Where do you go for what you need is a learning process, right? How do you understand who you are, including your identity as an autistic person, is a learning process. Administrative burdens are challenging in regard to financial issues. How much do you have to pay for that private evaluation? Some places around the world, there's an intensive wait list to even be considered for a diagnosis. And that means these people are enduring additional hardships because they're living unsupported lives. And then all of this falls under the rainbow of psychological costs. The original authors, Hendren Moynihan, wanted this to be a separate box, but in my dissertation, what I asserted was that psychological costs are interwoven with all the other costs. They can't be delineated out. The other missing piece that Katie Savin talked about in her dissertation that I adopted also is the idea of financial precarity. Autistic people, as well as other disabled people around the world, are actually financially punished for living with disablement. And that becomes really burdensome for people because how do we pay for the support we need to close the gap in accessing the services? This is compounded by stigma, ableism, and communication barriers. Yet the impact on the health outcomes is significant as people have to develop systems expertise at every tier of the developmental cycle. And that's an unreasonable burden, particularly for primary caregivers, often women pulling us out of the workplace, right?
Okay, so the conclusions. Today we get together here to discuss how to simplify the healthcare systems and reduce, as I mentioned before, the obstacles, and to propose the practical strategies for easily to access the healthcare systems for older people with autism in the futures. And our goal should build a more inclusive healthcare landscape for older people with autism in the futures. Thank you so much for your attention. This is our, yes.
Thank you very much. Would any of our think tank members like to comment on anything that was brought up by Shanli and Dena Gassner?
Thank you so much for your presentation. Is that on? Okay, thank you. So I think a lot about this and how can we make a business case to primary care or the hospital or rehab center, whatever it is, make a business case to show that the additional upfront time to really get to know the autistic patient, understand how to prepare them in the team, I believe it would be cost savings overall. How do we show that? How do we study that? How do we present that kind of data?
I actually think that there are people in this room that are really navigating that barrier. There's various systems, apps that are coming out and documents you can use that are considered like hospital passports that really help to describe how the person experiences the hospital setting, how to approach them. For example, my son is terrified of needles. So, you know, it takes an army to talk him off the ledge and to give him space. And that's also missing in the healthcare system is space and time. Many of our people need time to establish rapport. My son's IQ in an environment that's clinical is going to score in the 60s. With the person who decided to talk about video games with him, he scored an 85, and it was only low because he didn't bring a graphing calculator. So rapport is essential in the diagnostic process, and we don't have time for that. Did you have anything to add to that?
No.
Okay. Thank you. Go ahead.
I wonder if there are places in the world that do a better job than other places do. Are there ways that we could learn from other healthcare deliverers what has worked well and what about their attitude has been particularly good at following people as they age through their life rather than saying, well, you're 22, I don't serve you anymore, and then there's nobody to go see. I know I started out to phrase it, are there places that don't do this well? But I'm trying more and more in my life to think about the positive parts of things, and how could we look at people that are doing it really well? Anybody know someplace doing it really well?
You have to turn your mic off. Norway, Sweden, you know, they've been keeping records on healthcare systems for many, 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 many decades. And their systems are free-flowing. So if you have, say, seasonal affect disorder, and it makes it so that you're unable to work during the dark seasons of the winter, you go into the healthcare system and they provide you your housing and your meals and your food and your services. And then when the seasons change and you feel better and you're able to go back to work, you slide back into the workplace. It's an ebb and flow. It's not a challenge every time there's a transition in your system. And they're not perfect. Nobody's perfect. But I can tell you that we're putting together a special interest group for NSAR that focuses on this barrier of administrative burden because it's pervasive across the world in every environment.
So very briefly, okay, in Malta, there is work in progress, as Deputy Ambassador mentioned. We are looking at a cradle-to-grave approach, lifelong support approach to autism, but also to disability and vulnerability. So last June, Malta launched a bill for public consultation. It's called the Protection of Adults in Situations of Vulnerability Act. So it's being finalized and will be lodged, so will be tabled soon in Parliament. And one of its main elements is to have lifelong support plans for anyone who, from the age of 18 onwards, will be known by the system. So at that point, you don't have one file with social services, one file with primary health care. So and this way, then it'll be able to be ported over into old age also. So this is one of the systems where we're trying to bring together what we have in this country lodged in different systems.
And in closing, I'd just like to say that, going back to your question as well, in our current climate, you know, we can do policy work to change the system, right? But in our current climate, I think the answer is our social work sisters and brothers. I think social workers are uniquely designed to help with systems navigation. And I think that parents should be able to be parents, and professionals should be mastering these systems and expediting through those systems.
Excellent closing point. Obviously, we could continue discussing this important issue, but we will be moving on to Karen Turner of Massachusetts General Hospital and David Nicholas, the University of Calgary, who will be presenting remotely. Needs and capacity in long-term care and acute medical settings, including hospital admissions. Karen?
Hi, everyone. My name is Karen Turner. I'm an occupational therapist and in a unique role as a patient navigator for people with autism and developmental disabilities at Massachusetts General Hospital in Boston. And today, as we consider how to address needs and capacity, it can be helpful first to reflect on health vulnerabilities autistic older adults experience, as many of these conditions may ultimately lead to the need for acute or long-term medical care, particularly if not managed preventatively. Research has shown that health conditions associated with aging, such as heart disease, cancer, and osteoarthritis, are significantly more common among autistic older adults. Autistic older adults are also at a higher risk for falls due to more significant deficits in postural control and motor control compared to their neurotypical peers, as well as with higher rates of ocular conditions, refractive errors, and retinal disease. We have also begun to understand differences and disparities among the autistic population. Autistic women have been found to have more overall physical health challenges, higher rates of epilepsy, as well as hormonal conditions and ovarian cancer. Black, Hispanic, and Asian autistic adults are more likely to be diagnosed with hypertension. Autistic older adults with intellectual disabilities are more likely to have epilepsy, osteoporosis, GI conditions, and respiratory infections, whereas those without intellectual disability are more likely to have diabetes, high blood pressure, cerebrovascular disease, COPD, and suicidal ideation and intentional self-injury. Given this, we can anticipate that as autistic individuals age, they may have more complex or prolonged inpatient admissions. Oh, I'm sorry, as they age, that their care will become more complex and interactions with the healthcare system will be more frequent. They will encounter an increasing number of specialists, which then places them at risk for increased fragmenting of care. This means more disruptions to daily routines to attend visits, blood draws, procedures. And when acute care is needed, they may have more complex or prolonged inpatient admissions. At least in the United States during this time, many times their medical teams may rotate numerous times across their stay due to the nature of our system. This also means longer exposure to uncomfortable sensations in the environment. And furthermore, access to knowledgeable support persons may change with age. The value of support persons as advocates and facilitators for communication cannot be overstated, particularly at the bedside. However, for the autistic older adult, their supports, whether a spouse or partner or a sibling, may also be aging and less available to directly assist. The experience of adult children in supporting the healthcare needs of autistic older parents is unknown. Meanwhile, barriers to care persist, including communication, sensory, and environmental barriers, as well as providers, clinicians, and staff who are unprepared when patients arrive for care or have limited understanding of autism. Healthcare providers and clinicians face barriers too. In the US, significant workforce turnover has occurred since the COVID pandemic, resulting in the loss of many seasoned clinicians who, by nature of their experience, had strong skills in adapting their communication style and modifying medical tasks. For new providers and clinicians entering the field, even if basics on autism were included in their training, this does not necessarily mean they will be able to seamlessly apply that knowledge within the context of their role, the care the patient needs, and create accommodations needed to make medical care more accessible. Workplace violence is also a significant concern, with U.S. healthcare workers experiencing verbal or physical assault from patients in general and their visitors at a rate of nearly 4 times other industries. This trauma most certainly affects providers and clinicians, and a trauma response coupled with lack of education and experience may lead to more reactive responses on autistic individuals' behaviors of distress, which are likely also based in trauma. Yet grounded in this are providers and clinicians who are genuinely interested in learning how to help. And when empowered with the support, knowledge, and tools they need, they experience success, and you can see the light turn on inside of them. As there is no better motivator to continue to do better than being on the receiving end of gratitude from autistic individuals and their loved ones after a successful episode of care. And that brings me to my first question about training. And as we know, limited provider and staff training and awareness persists as a challenge for autistic adults. Yet a lot of efforts have been put in to create frameworks and trainings. And yet I question if our current methods for training are somehow missing the mark or failing to kind of meet the needs of our providers and clinicians and staff in a way that it makes it accessible to them within the demands of their roles. Do we fully understand what our healthcare workers need, and how can we do better for them so that they can do better for autistic older adults? With that, I'll open it up.
Okay, well, thank you. Now we have a pre-recorded video from David Nicholas, so if we could get that on the screen.
Hello, I'm David Nicholas from the University of Calgary. I want to reflect on needs and capacity in long-term care and acute medical settings and build on some critical needs that were identified in our last Autism and Aging think tank in 2023. There is substantial need for capacity building and training among interprofessional healthcare teams and providers in supporting the range of needs of autistic seniors in long-term care and medical settings. We need to think about critical areas, for instance, the impact of medications over time, supports required to address the range of health and developmental needs of autistic seniors as they age, including end-of-life care. Long-term care and health environments can be highly challenging from a sensory perspective. How can we render these spaces and contexts more amenable? I particularly appreciate Dr. Mary Doherty and colleagues' autistic space framework and emphasizing the acronym SPACE. That is S, sensory needs, P, predictability, A, acceptance, C, communication, and E, empathy. This is such important information offered by Dr. Doherty and team in helping us critically reflect on long-term care, medical care, and even community care environments and processes of care. We need to think about assessments and how they address and need to address relevant health issues, experiences, and care considerations for aging autistic seniors. Screening for health issues in aging must be more accessible. We need to think about how dementia may intersect with autism and potentially developmental or intellectual disability and the supports needed. These are such important areas of which work is underway by colleagues, which we need to partner with and learn about. Also, as we think about our aging autistic community, we need to ask, what are the needs of people who provide support and care? That is the caregivers. As we move forward in considering autism and aging, it seems important also that this work is centered in an understanding of trauma, reflecting the likely and so unfortunate experiences of autistic people who have likely have faced barriers and imposed challenges over a lifetime. Advancing focused training for healthcare and community care providers is critical. Indeed, there is much to be done. As I think about that, it seems that partnership with other relevant fields and sectors is so important. For instance, targeted collaboration between autism-specific organizations and mainstream aging services may help us gain traction and build collective capacity. In this work, a human rights perspective is crucial, with principles such as agency and self-determination among aging autistic people. This offers important implications for care planning, advocacy, capacity building, practice standards, and policy development in making aging and autism a priority in our funding structures. In all of this, there is crucial need to hear the voices and perspectives of aging autistic people. In particular, to not lose sight of that important value, nothing about us without us. Thank you.
Roughly 5 minutes to open up the floor to discussion. Would anybody like to comment?
Mary, I'm hoping you can help me, but I know when we were at the Autism Congress in Ireland, one of the other medical persons there, and I tried to find their name and I couldn't, talked to us about new findings about correlations between hypermobility conditions and co-occurring Parkinsonian behaviors that are coming up in autistic people. These are relatively new findings, I think. Do you remember who it was that spoke to that? List of things that are magnified for autistic. I mean, the joke I always have is every December I get 2 weeks off for holiday and I have to figure out what part of my body I'm going to fix this year, you know, and it's cute and charming, but I really have been hospitalized nearly every year because of the hypermobility implications of aging with co-occurring Ehlers-Danlos. So I think we need to be expanding our thinking that way too.
I think, a better understanding of the really complex medical presentations that people are coming to the hospital with, because there are patterns that I'm seeing as a clinician caring for people, and can offer that to people as a reassurance, like you're not alone in that there's this constellation of conditions you're coping with. And I think I want to echo the question that Melissa raised with the first presentation too, around what else can we be doing to understand how healthcare organizations prioritize projects and initiatives, whether it's having a better understanding of data. So we really don't know what's the average length of stay, what's the average readmission rate, how are the patient experience kind of scores different for people with autistic people versus neurotypical patients. What are the safety risks in the hospital? How are inpatient safety events occurring? Are they more frequently occurring to people on the spectrum? These, at least in my hospital, I know are data points that are regularly looked at and examined, and I'm hoping that this is an area that more work can be done in to continue to advocate for the need. And how to be able to get resources, because it's true. I am one individual, doing a lot of work to support proactively people coming in, but we need more people doing the work.
Sure.
For one more comment?
Additional point I want to share in reference to the need for training and also what you mentioned with Ehlers-Danlos, I'm thinking about my patients who have shared their experience of diagnostic overshadowing, times when they're meeting, whether it's primary care or more acute settings, and then the provider may share, well, it sounds like this is the autism or this is the sensory stuff, the anxiety, where it gets shadowed and then time goes by and the problem amplifies. So I think looking at training, making sure that we are also addressing diagnostic overshadowing and these implicit biases as well. Thank you.
People on the team who are comfortable with advocating in those moments of saying, well, but do you really think, what about getting GI on board or another service on board? And showing people, look, here's a pain assessment tool for people who are non-speaking. Could this be pain instead of behavior? So yes.
It's a whole body.
For that stimulating discussion, we are going to move on now to Robert L. Hendren, University of California, San Francisco, and Margaret Bauman, Boston University School of Medicine. They will be discussing the impact of medications on autistic individuals during aging and physical and mental health challenges associated with aging. Robert?
Thanks. It's a pleasure to be able to do this as partners with Dr. Bauman and myself. Dr. Bauman is a neurologist. I'm a psychiatrist, and we both started our careers working with younger kids, and now we're working with older people. And it's been a learning experience to go through the lives of people and see what happens to them, and to see many times healthcare systems want us to move back to seeing younger kids and not stay with the people that are aging. And yet there's a sense of having joined the family that I feel like I want to stay with them. And so there have been interesting studies, one recently that ended in 2022, but was published last year, that said among 26 to 34-year-olds, there's been a 450% increase in the diagnosis of autism. So as we think about that wave of people that started at a young age and then we keep going up, I think that wave is going to keep going up, and we don't understand a lot about the medical issues or about medications that happen to people as they go through that time. We know that people with autism have increased rates of things like cardiovascular disease, motor disorders, ear problems, urinary problems, digestive problems, side effects from long-term medication use, non-specific lab tests and encounters. In contrast, the only thing that could come up in this study that wasn't increased was cancer. There seemed to be less cancer in this group as they aged. But as we look at that and we think about medications, one that stands out are anticholinergic medications. Lots and lots of things that people take as they get older are things like things that are used to treat allergies or asthma or epilepsy or even Parkinson's disease. Then looking at even antidepressants and a variety of other medications, and people get more sensitive to anticholinergic medications, and it makes it often so that their cognitive abilities are impaired, which happens to everybody, but people with autism might be particularly vulnerable. So as we think about medications, how to deal with that as people grow older, that's often something that people are not trained to do or think about, oh, maybe it's the anticholinergic medication that's causing this cognitive loss, rather than, oh, it's just part of autism. Maybe there's something that I could do. I think people had mentioned the extrapyramidal side effects, but we've increasingly been recognizing things like the Parkinsonian increase in people with autism, and it's not solely related to their taking medications that cause Parkinsonian-type symptoms, but it seems to be something that seems to go along with autism and aging. The other one that's deeply concerning to me, and I think is poorly understood, is some association perhaps to dementia. There have been some studies that say there might be an increased risk of dementia as people with autism age. Other studies say no, those studies are faulty, but we don't have enough good studies to really say how do we parse out, what is autism aging and what might be dementia aging, and how can we effectively think about how to treat those things. The other issue, I think, are medical comorbidities that I referred to earlier, but as we think about those aging effects on the body, things like GI symptoms, things like hypertension, diabetes, and then I was talking, somebody coming over, just sleep problems. How do you think about sleep problems in aging and sort that out, and especially so with people with autism? So I'd like to go on, but we're sharing this. So I'm going to pass it to Dr. Bauman. Oh, I need to turn mine on.
Oh, okay, great. Thanks so much. The comments that have been made already have been right on target. And I'd really like to emphasize the need for training future generations of specialists, regardless of whatever discipline they have. And we need to educate our physicians, but also I think social workers have already been mentioned, physicians in any kind of discipline whatsoever, because many of the healthcare issues that are presented in children tend to persist or show up in adults as well. It's not like they're going to just go away. So we need to be able to train people in terms of all kinds of disciplines. The second thing that's already been discussed in part is the fact that many of the individuals on the autism spectrum don't necessarily present with healthcare symptoms that are easily recognized by the average uneducated, I guess, or untrained or unaware professional, whoever that might be. There is a concept called interoception, which means how do you interpret internal body feelings. And I think that we have a situation, in some cases at least, where many people on the spectrum don't interpret well or localize their pain and discomfort, for example, and it can exhibit by various behavioral abnormalities, which then, I think as already mentioned, can be misinterpreted as best being the part of the autism story. So I think that all of this is still part of the adult story that needs to be mentioned, and I'd like to hear more ideas about how people think we might be able to be a little bit more proactive in terms of training going forward. The second comment I'd like to make is that what Bob has already talked about is this issue of dementia. The issue of dementia has come up in several sort of long-term data analyses. So for example, in the United States, Kaiser has a database, and you look at the database, and they have a database that looks like autism and how many people are diagnosed with dementia. My question is, who's making the diagnosis of dementia? What do they mean by dementia? How are they defining dementia? I don't even know what that really means. I'm not even sure, quite honestly, how people are making the diagnosis of autism in adults. If you want, I know a lot of adults are now being self-diagnosed, and indeed many of them are absolutely correct that they've been missed. But I also am not clear about who's making these diagnoses and how accurate many of them are, because I think that's also a crucial piece. But this issue of dementia, I think, also needs to be pursued along with other possible medical comorbidities. Thank you.
Thanks to both Robert and Margaret. I'd like to open up the floor to questions or comments. Vanessa?
I think all the comments today really started to hit on the importance of training, and that we predominantly think about autism as the child or the family or the pediatric tracks in training, and we need to push for, quote, adult tracks or lifespan tracks. But I think we're also, practically speaking, asking a lot of our providers to become experts in their field and in autism. We need to be thinking about integrative healthcare and bringing in people, social workers, psychologists, other professions, and have a more integrative, sort of supportive environment where we're bringing people in. But again, not focusing on child and family. Everyone should have some training in autism across the lifespan.
Just to build on that, one thing that I've heard a lot from my patients is that even the ones that have gotten a diagnosis of autism and are advocating and saying, I'm autistic, I need you to consider this in the care. I think what I've heard is a lot of the healthcare providers don't know what to do then. So even the training, even if they have training, it's more about what autism is. And I wonder if we maybe need to do a lot more training on what to do in those situations.
I could spend a lot of time talking about what to do, and that's all to do with the autistic space framework, which you might come to in a little bit. But I wanted to specifically mention about dementia and make the point that we don't know what ADHD looks like in the older population. And as one of the, aging autistic people with a co-occurring diagnosis of ADHD, I can see that there's a lot of overlap there and there's a lot of confusion. And it's quite likely that some older autistic people are potentially misdiagnosed as having early onset dementia, when actually it's just, that's what ADHD looks like in this population. And we need so much more research because most of us are multiply neurodivergent. And of course, it's only recently that the ADHD, the co-occurrence, is even recognized. So we need to catch up with that.
Just a question to Dr. Bauman. When you say like a dementia, like who's diagnosed with dementia, so you don't think they are referred to the neurologist, like who can conduct the screening tests and the markers, like even the blood test has come up. So, I mean, you can, or the brain imaging testing, PET scan, which can, these are the, if they are referred to the specialist rather than the primary doctor giving a diagnosis, most of the time they should be referred to the neurologist who are specialized in diagnosing.
Honestly, I don't know, in large part because most of the data that I've seen at least have come out of these databases, and so it doesn't always identify how it was done or by whom. I think that Mary's comment is well taken, particularly given the data that we also know about. Once an autistic person, many autistic persons leave school, there's data that says that lots of their skills tend to decline because their lack of stimulation. So is that what somebody's interpreting as being, quote, dementia, that they're losing skills because they're not being stimulated, particularly along the lines of the individuals who are nonverbal, for example, or non-speakers? Oftentimes they don't have opportunities in the community to be participating in various programs. So honestly, I don't know. And I think it's an area that really needs to be explored. Dena?
I wanted to point out that, the biggest problem with the training is that people think of autism as a specialty. And I went to the National Association of Social Workers Conference. I put in a proposal. I've keynoted around the world. I had one other person in the room with me because we live under the myth that it's something that happens over there. And I always say, if you're working with people who are unhoused, you're working with veterans, you're working with survivors of domestic violence, you're working with people with chemical use problems. You are working with autistic people and you're underserving them if you think they don't exist within your subpopulation. And so I think that's the first myth we have to explode. I also want to talk about reproductive health care issues, not necessarily at childbirth, although our findings around that, Margaret, are very staggering. And the problem is they keep recording the data based on the primary presenting problem. So if you have autism, it may not be identified because something's louder. But the other problem in accessing these systems is we don't have those navigators in between, translators. People can help people communicate. And so we're talking about building an entirely new workforce. We have the roots, but we haven't really worked on doing that.
I'm just going to go ahead and add one other thing. And I just wanted to.
This is bad.
No, it's good. It's all the energy over here. I just wanted to go back to a couple of points really quick, and that was as far as additional training. And then also, I'm sorry, I wanted to make the point that beyond the strategies, the specific strategies about how to put the amazing frameworks in place, we also need to look at the processes that are occurring at the ground level and how can we embed this information in what healthcare workers are using every day. So that may be incorporating care plans directly into medical records, so that if you went to a talk 3 years ago and you don't remember those specific exact strategies, it's there in front of you what will work best for this person. So just wanted to add that as well, that I really think work needs to be done, not just on the people training, but on the process improvement piece too.
We have a comment that came in remotely. This is from Hetka Puki. The theme of aging is highly relevant to the European Council of Autistic People. Many of our member organizations were founded 20 or more years ago, and many of us autistic activists who started these organizations and have been engaging in advocacy throughout the years are now facing aging and all the challenges it brings. We see European countries moving towards cutting disability services for older adults, even as many of us still struggle to have our disabilities recognized or have failed to get access to diagnostic services in the first place. Often this has been on the basis that clinicians assume that the diagnosis would not provide access to any services or that we could benefit from any. Major issues concerning autism and aging from our perspective include providing screening for health conditions that commonly co-occur with autism and that can start affecting functioning later in life, investing funding and research on health and quality of life in older autistic people and the development of services that can deliver the benefits of such research to the autistic people, investing in research to map the effects of poverty on the health and functioning of older autistic adults, and providing diagnostic services for adults, especially older adults, in countries where these do not yet exist. We hope that organizations such as ours, representing the collective voice of numerous older autistic adults, could be more closely involved in policy work and research concerning us. This would require better resources, as practically all autistic people who could directly advocate in these matters are in poor situations and need support to engage in any way. In most countries, the situation is worse, preventing people from even trying to form organizations such as ours.
And that email was from Hedda Puke from the European Council of Autistic People, who is watching this remotely and had been asked to share some thoughts. Okay, any other comments regarding Bob's and Margaret's talk?
I would like to just add one point. Dr. Wen Lawson at one point said he knew something was wrong with him, and I'll always remember him sharing this story. He knew something was wrong. He didn't know what, so he went to the doctor and said, "Something's wrong." The doctor asked, "What?" And he said, "I don't know, that's why I'm here." And the doctor literally started squeezing at his toes and worked all the way up until they found the problem. That is the sort of solution we need physicians to take in these situations, because as Margaret rightly pointed out, interoception is a huge concern when it comes to understanding where pain is localized in the body. So thank you for sharing that, Margaret.